I'd like to apologize that I can't be there in person today and provide this talk, but I hope through the recorded version, I'll be able to share some information and live up to the expectations of both Jens and Rod. I'll start by acknowledging that I really enjoy this opportunity. Every time I have an opportunity to talk with the Seattle Science Group, it's a pleasure and privilege. So thank you, Jens and Rod. I have nothing to disclose except that to follow Failings, Steinmetz, and Resnick is definitely a hard act to follow, particularly when they've covered most of everything there is to do with spinal cord injury already. So I was asking myself, what should I talk about? And I decided to mix it up a little bit and thought I would talk about things that make me grumpy. And so specifically, I want to talk about three things that make me grumpy about spinal cord injury. So I'll lay it out. The first thing that makes me grumpy is mean arterial pressure. And you'll probably all remember that the real push to push maps, no pun intended, came from the guidelines published in 2013, where we recommended the maintenance of mean arterial pressure between 85 to 90 millimeters of mercury for 7 days in patients with acute spinal cord injury, which by definition means an ICU. And that came about because primarily of Hadley's paper from Alabama, where they looked at retrospectively patients who were admitted with Asia grade A, B, C, and D. And they found if they pushed the maps, that the percent ambulatory capacity, patients that left the hospital walking, were 3 out of 10 patients of their Asia A's, 5 out of 6 patients of their Asia B's. And compared to historical controls, that's quite remarkable. So that's really the backbone. There's some basic science literature too. Since the guidelines have been published, there have been a couple of papers that are pretty much recommending the same thing. This is Sanjay Dal, Jeff Manley, Greg Harlock out of San Francisco, showing that mean arterial blood pressure correlates with spinal cord injury outcome. Here's another paper by the same group in 2016, similar set of patients, tremendous amount of data from ICU going into these patients. And more recently, here's a paper from the Barrow, from Laura Schneider and her group, which also shows correlation. And that is the problem, I think, that we need to be very careful about. The other thing that Laura showed was that this is expensive, $220 to $350 million per year in this country to maintain maps in our spinal cord injury populations. Here's the problem. The reason we're pushing maps across the whole range of Asia patients is to push perfusion into the spinal cord. And we're trying to treat neurogenic shock. But what's wrong with this picture? When you look at this picture, what's wrong with it? What's wrong with it is that neurogenic shock doesn't happen up here. Neurogenic shock, bradycardia hypotension, happens down here. And so if you look back at these papers, what they're showing is that there's a high correlation between hitting your map target and neurological improvement after spinal cord injury. Guess what? It's easiest to hit your map targets in this group up here because they don't really need map support in the first place. The worse your injury, the worse the map. And not surprisingly, if you hit your map targets easily, you get a better spinal cord outcome. And that's because you've got better prognosis to begin with in less severely injured patients. So the real study that I think is trying to drill down into this is by Marios Papadopoulos in the United Kingdom. They're using microdialysis catheters in adult patients with spinal cord injury, and they really have had a hard time showing that changing the perfusion makes a difference in spinal cord injury at all. So hard that they haven't published the results yet. So MAP is expensive. There's some basic science literature that suggests it's going to be beneficial, but in over 10 years of guidelines, we haven't been able to really show anything other than prognosis is related to severity of injury. The second thing that makes me grumpy is MRI is a poor indicator of ligamentous instability. And I'll explain this a little further, but How many of you in your level 1 trauma centers are faced with this kind of report from the radiologist? Discontinuity of the ligamentum flavum at the levels of C3 to T1, concerning for ligamentous tear and associated interspinous ligamentous edema, most prominent at 4, 5, and 5, 6 levels. Ligamentous tear. Then the trauma team says, unstable injury, consult the spine service. We go and see the patient. Here's the MRI. I hope in the audience you're saying, what's wrong with that MRI? Well, the radiologist says this is where the signal change is in the ligamentum flavum. And if you look at the axial images, here is an indication. This is the dura, and this is the radiologist's interpretation of the ligamentum flavum. And this is an intact segment of the ligamentum flavum, and this is a disrupted segment. Similarly, a little bit lower, we have the same thing. Here's the intact ligamentum flavum, and then here's the disrupted ligamentum flavum right here. And so we have to see this patient, who's a healthy young female and has beautiful flexion and extension films. And what the radiologists don't understand, and I hope that this audience does understand, is that in order to disrupt the ligamentum flavum, you have to disrupt a number of other ligaments in the process, including the interspinous ligament, the facet capsules, and even to a degree, the PLL, just to get to the ligamentum flavum. So there's a failure of understanding of biomechanics and three-dimensional anatomy when we're faced with these reports, and the trauma team doesn't know any better. We looked at this closely over a 2-year consecutive case cohort. We took all the consults where we were asked to clear the spine because of an abnormal MRI in the setting of a normal CT scan. 33 patients over a 2-year period all underwent extended full spinal precautions in the ICU. They all had normal flexion extension x-rays. They all had their collar removed, and none of them had surgery. None of them returned to the ED in the 2-year period of follow-up. So that's a message that I'm still amazed when we're doing our case conference and we ask the residents, what would you do next? They said, get an MRI to look and see if the ligaments are intact. I hope we can continue to change that philosophy. The third thing that makes me grumpy is that the 21st century spinal cord injury, the new pattern of spinal cord injury in the 21st century, is spinal cord injury without fracture dislocation, or central cord syndrome, which we've heard about today. We took a look at our level 1 trauma center in a 1-year period to try and figure out what our demographics were of spinal cord injury in 2021. A retrospective review, January through December. We looked at all spine service consultations that came in through the ED. We looked at all admission and OR notes. We scrubbed all clinic notes, and we even searched the electronic database for ICD-10 codes to try and get any patient that was admitted for spinal cord injury during that 1-year period. We didn't want to miss anybody. We broke this down into 2 injury types. We came up with 51 patients, and we broke them down into spinal cord injury with fracture dislocation and spinal cord injury without fracture dislocation. This is all cervical spine. And here's what we found, that the demographics for our 1-year snapshot at our level 1 trauma center showed that 80% of patients that have spinal cord injury now, for us, have no fracture dislocation, and only 10% have fracture dislocation. So the vast majority of patients we're seeing in the 21st century do not have fracture dislocation, quite different from when the NASCA studies were published. We looked at mechanism. If you think about high impact mechanisms, motor vehicle accidents, sports, the fracture dislocation group had a very high incidence of high impact mechanisms. Whereas, no surprise, the no fracture dislocation group had a high incidence of low impact trauma, ground level falls. If we looked at pre-existing spinal stenosis, here is our fracture dislocation group. Only a small number of patients had a congenitally narrow or degeneratively narrow spinal canal, whereas the majority, close to 100%, 41 out of 42, had pre-existing stenosis. Asia grade, it was interesting. Here again is our, in orange or red is the non-fracture dislocation group. And you can see, I'm sorry, this fracture dislocation group. You can see in people that break their neck, they have a high incidence of Asia A, Asia B, and Asia C and D are less. Whereas in people that don't break their neck, much higher incidence of ASIA D and ASIA C or incomplete injuries. And finally, if you look at the propensity to injure hand, arm, or leg, here you can see when you break your bones or dislocate your bones, that there's a reasonably similar incidence across the board of hand, arm, and leg motor involvement, which suggests non-discriminating involvement of white matter and potentially gray matter pathways. Whereas when you don't break your neck, no fracture dislocation, you can see hand deficits rule, and then arm comes in second, and then leg has a lower propensity to be injured when you don't break your neck. So in perspective, we're dealing now in the 21st century with a very discrete group of what we would call previously central cord syndrome patients. But when we look at them from the perspective of non-fracture dislocation, spinal cord injury without fracture dislocation, we're really looking at a spectrum. You can have a central cord syndrome all the way down to an ASIA A, and a central cord syndrome all the way up to ASIA E, which means that we probably have to redefine central cord or call this by an acronym that's a bit of a tongue twister: spinal cord injury without fracture dislocation, now representing, at least at our level 1 trauma center, the vast majority of spinal cord injuries we see. This trend was nicely identified by Bijan Arabi and his group before I had anything to do with it, when they looked at over 1,400 patients trending from 2001 to 2018. So we know that the demographics of spinal cord injury without fracture dislocation are pre-existing stenosis, low velocity, low impact, and selective hand injury, including numbness and weakness. Have you ever asked yourself, why do they get selective hand numbness and weakness? If you haven't, I don't care. I'm going to tell you anyway. Here's a cross-section of the cervical spinal cord. And you can see that these are your descending motor fibers coming through, say, corticospinal pathway, synapsing in the anterior gray and leaving as your alpha motor neuron, or your secondary motor afferent. Here are your ascending sensory fibers, primary sensory synapting in the dorsal gray, and then crossing, as they must, through the central gray to ascend on the opposite side in the spinal thalamic system. Now let's layer over this the microvasculature of the spinal cord. And you can see that that is devoted primarily to gray matter with much less spinal cord perfusion in the white matter. Oh, by the way, here are your ascending and descending long tract, white tract axons, myelinated axons, ascending and descending through the spinal cord. Now, considering the orientation of the axons here as opposed to here, and the microvasculature, when you get ligamentum flavum and disc osteophyte buckling towards the center from a hyperextension injury, low impact fall, then that causes dispersion of these elements laterally, which is going to disrupt the sensory fibers crossing over to the other side. It's going to preferentially disrupt them, as well as the microvasculature in this area. And that's going to leave you with hemorrhage or contusion inside the gray matter, which is also going to disrupt those transversing axons, not so much the ascending and descending long tracts. So a mild injury, as you might expect, is going to be focused here and hit primarily those sensory ascending fibers, which is going to cause hand numbness. With a bigger injury, you're going to start to disrupt synapses and traversing primary order motor neurons, and that's where hand weakness is going to come in. And you can get more severe injuries than involving the arms and eventually involving the white matter pathways down here. No better illustrated than in this example of a modest central cord injured patient, where on the axials, you can see a beautiful outline of the gray matter indicating hemorrhage inside the gray matter in the acute setting, selective to the gray matter. So the severe injury can cause the ASIA A's and ASIA B, the B patients that we're talking about, well outside of hand and arm dysfunction. So it's a different mechanism, it's inside out, and it makes me grumpy because of the surgical timing issue, which in my opinion, we are in equipoise. If this is a line dividing evidence for early surgery versus evidence for no surgical timing based on injury, there's a lot of publications, and some of them are on the fence. These two were interesting for me because here in the central cord syndrome in Wales, 60% of the patients are non-operative. 75% of spinal cord injury without fracture dislocation in North American trauma centers are still non-operative. And that has to be accounted for when we start considering guidelines to tell us when to operate on these patients. There is some intelligence and experience or wisdom in the community, despite what the people with the loudest voices might say. Here's paper that is on the fence, but when you drill into it, spinal cord injury without fracture dislocation, no difference from early surgery. Spinal cord injury with fracture dislocation, perhaps, yes. And there are other papers when there's just stenosis and no fracture dislocation showing that early surgery doesn't matter. And then there's one paper I found that does show potentially that spinal cord injury without fracture dislocation may benefit. But this paper at the bottom is the one that I wanted to spend just a couple minutes on. Published in Journal of the American Medical Association Surgery, JAMA Surgery in 2021, early versus late decompression for central cord. An interesting paper at the beginning because it combined 3 huge databases for spinal cord injury patients, NACTIM, NASCUS-3, and STASCUS, for a total of 1,600, almost 1,700 patients in a harmonized data set. But when you look at the patients that they could analyze, they started out with 1,600. 323 had central cord syndrome, which they defined as lower motor score is better than the upper motor score. And that's so by definition, we're talking about motor incomplete patients, no A's, no B's. These are Asia C's and D's. They had 300 with baseline data, 93 went in with early surgery, 207 had late surgery, but the authors wanted to propensity score match. So they tossed out over half of these patients to find 93 patients that had late surgery that were of similar case constitution compared to the early surgery. And they had 75 with follow-up data. So here we are. Here are our propensity matched Asia C and D central cord syndrome patients, 75 early, 73 late. Here's the data. This is the difference in Asia motor score. In the upper extremities, early versus late surgery only improved the Asia motor difference by 2 points. Statistically significant, but only 2 points. In the lower extremities, 1 point, not significant. In the upper extremity and lower extremity combined, 3 points, not statistically significant. FIM score, by the way, negative. So in order to find something interesting, we'll throw all of those patients away and we'll look just at the Asia C patients. 20 earlies and 24 lates. Here are the results. In the upper extremities, there was a 5-point difference between early surgery versus late surgery in the upper extremity score, not statistically significant, by the way. And that's where they have their highest deficit, right? By definition. In the lower extremities, 4 points difference, statistically significant. When you add those two together and run the stats again, you get a difference of 9.5 or almost 10 points in the Asia score comparing early versus late. But we're really looking at 14%. We came from 323 patients with central cord injury in a huge database collection. We're down to 14%. And this was published in JAMA Surgery. Really? Really? I can't get that kind of thing published in JAMA Surgery. By the way, in the 3 databases that were combined, 85% of those patients were spinal cord injury without fracture dislocation, and 60% happened from motor vehicle accidents and sports. So at conservatively, if we get rid of 60% of those patients because they have fracture dislocations, we're dealing with the data set we're looking at, no fracture dislocation, 10 to 12 patients in each group. So in my mind, before we start dictating that all of these central cord patients should be operated on early within 12 or 24 hours, let's take them in. I think we're at a point of equipoise. We've got a different mechanism. The evidence is all over the map. And it makes me grumpy that we're still looking at maps without good evidence. MRI is a poor indicator of ligamentous instability. And then in the 21st century, central cord syndrome is our most common spinal cord injury. But surgical timing is not necessarily following the same rules because of a completely different mechanism. I would remind those in the audience that are old enough to know about the New England Journal of Medicine publication that came out in 1990, telling us that we had to use steroids within 24 hours. It was really hard to turn that over. It took 20 years to turn that data around and show where the truth lay. I don't want to get caught into the same problem in early versus late decompression for people that haven't broken their necks. And I hope we can avoid worshiping the Trojan horse for another 20 years and use common sense and put some real science behind our conclusions before we make mistakes again. Thanks for your time. Sorry I can't be there.